thank you everyone for being here. And we're going to try to piggyback a little bit off of the couple of great panels to start the day and focus this discussion on provider consolidation and more broadly consolidation in the healthcare space. And we have an excellent panel of experts who are gonna support speaking about that. But I'll just do a quick introduction of myself first. I'm Paul Shorkey. I'm a managing director at Boston Consulting Group, based out of Raleigh-Durham here. I spent a lot of my time in the healthcare M&A space, helping usually large not-for-profit health systems look at M&A transactions. And then my other hat I wear is more on the talent side, helping health systems figure out how to retain, in particular, clinical talent, which I'm sure will be a topic we'll spend some time on the panel today. And then I'll pass it to the others to introduce themselves.
Hi everybody, I'm Yashaswini Singh. I am a healthcare economist by training, and I'm an assistant professor at Brown University at the School of Public Health. My background is in economics and mathematics. I got my PhD from Johns Hopkins. Before that, I did a stint in the private sector, doing some consulting work. Research interest-wise, I studied consolidation in healthcare markets, specifically focused on the role of private equity investors in shaping the way healthcare is delivered, practiced, received, everything in between. Pleasure to be here.
And if you don't follow Dr. Singh, you probably should. If this is what you all are interested in, you should have those little Google Scholar alerts whenever she publishes something. You'll look silly if you don't know what she writes. I'm Paul Hain. I'm the Chief Medical Officer at a company here called Salehizadeh. I started my career in academics as a pediatric hospitalist at Vanderbilt, then at UT Southwestern, then I was Chief Medical Officer of Blue Cross of Texas, and now I am the CMO of Salehizadeh.
Hi everybody, Bijan, Salehizadeh. I work in private equity. I run a healthcare private equity firm in Washington, D.C. called NaviMed Capital. During the conversation, we'll get into what we do. But one thing we don't do is buy physician practices, but I'm happy to talk about that because I love talking about why we don't do that. Before I got into private equity and venture capital, I trained as a physician. So I went down the path of doing all that training and then decided I wanted to exit stage left and get into industry. That was about 4 or 5 years ago. Nice to be here.
Great. Well, just to set the stage for what we'll talk about, I'll briefly share, a little bit of foregrounding here. But obviously, the consolidation in healthcare markets broadly, and particularly in relation to providers, continues. In North Carolina, here our state, Kaiser will acquire Cone Health, or at least announce that acquisition through Risant will happen over time. And it's interesting in looking at some of the statistics. In today's world, in 2024, around 80% of physicians are now employed, either by hospitals, payers, large corporations, right? So that's a very strong departure from what that statistic looked like only a decade or a decade and a half ago, where only, say 30, 40% of the total workforce was actually employed in that way. And the corporate ownership of sort of practices, it now exceeds the ownership by hospitals and health systems. So again, there is certainly, as we're all aware, a pretty significant shift in ownership and employment, particularly on the physician side. And so with that as a foreground, I wanted to open it up to our panelists to talk a little bit more about some aspects of that. And obviously there has been that big shift in employment. So would love to open the question with what market forces and physician preferences are actually driving that change, and what advantages and disadvantages are physicians sort of seeing under these new corporate entities that are forming. So Yashaswini, maybe I'll give it to you to start.
Sure. So I think of market forces as maybe being twofold. The first is, entities that start out with the intention of practicing independently. In the last 5 or 10 or 2 decades, we've seen they're being increasingly acquired through mergers and acquisitions by larger entities like the health system. So the first market force, I would say, is this kind of emerging wave of consolidation, which has taken several different forms, right? You have your traditional horizontal consolidation, you have your vertical consolidation that's been gaining ground, but then also looser forms of integration where you might have contractual affiliations that are probably included in that 80% statistic. You have consolidation in some form or nature by private equity firms. And so this first market force I would characterize as just a growing presence of corporate entities that are increasing their footprint of acquisitions of providers. And then the second force I'll just add briefly is kind of a push and pull, right? The practice of medicine, as I'm sure my other co-panelists know, is incredibly complex. And so it's become increasingly difficult to remain an independent practice because of issues related to compliance with value-based contracting programs and investments in technological procedures and tools and platforms. And so there's a need for capital, there's a need for financing, and a lot of these entities that come in to consolidate are filling that gap. And so I kind of see it as a twofold push and pull.
I have zero to disagree with there. It's also very smart not to disagree with the only economist on the panel.
Could you speak louder?
I can speak louder. The only thing I would add to that is if we're talking about market forces, a lot of this has to do also with the physician marketplace, right? So if you assume that a physician practices for 30 years, that means you're going to lose 3% of your physicians every year and you're going to gain 3% coming out of residency. So over 10 years, that's a lot of turnover, right? And folks coming out now see these same forces of, wow, it's really hard to start a practice, value-based care is really difficult, I'd have to buy an EMR. Just in my time of watching medical practices, medical leases have gone from 3 to 10 years. So you used to be able to sign up and open shop, and you only had to sign a 3-year lease. Now you have to sign a 10-year lease. So you're coming out of residency and guaranteeing that you won't move for 10 years? It's really hard. And so you also have that physician push of, I'll just go get hired.
And I think just one thing to add to that, it's the market forces and the underlying causes that Paul just went into are amplified by the availability of private capital, which is but one of the vectors that Yashaswini mentioned. But there has been an explosion in private capital, not just in healthcare, in all industries, private equity, venture capital over the last 25 years. And if you're a physician practicing and a private equity firm comes to your practice and said, I'd like to buy that practice from you, I don't fault physicians for wanting to sell and capitalize some majority percentage of the thing that they've built. They typically are in their 50s, often late 50s when they do that transaction, not always, but often, and are not sure what the retirement path would be if they went down the old way of doing it, which was sell your share to your partners, which was the old way. So on top of all the challenges that it is to be an independent physician, there's this bag of money out there that's saying, come join us. It could be a nonprofit health system's bag of money or a private equity firm's bag of money. And I don't fault those physicians for taking advantage of that capital availability. Now, what happens after that might be the whole rest of this panel if you do one of those transactions.
Well, I do want to spend just one more second on the financial motivations, though, because I think it's a very good point. Right? There is the world is awash with capital in healthcare and more broadly in a way that wasn't the case many years ago. And so just clicking into those financial motivations, right? The revenue growth, the shareholder return, the increasing need to drive efficiency in, both not-for-profit and for-profit settings, right? To sort of get to a margin profile that's reasonable. How do you all see those financial forces impacting consolidation, and how do not-for-profits navigate them? And maybe Paul, I'll go with you first.
And I'm sure Dr. Singh can hop in and help me where I misspeak about the literature on this. In between the not-for-profits and the for-profits, like if you're talking about hospital systems, there's not much of a difference in how they operate on a day-to-day basis. The not-for-profits may have the luxury of planning year by year instead of quarter by quarter with investor calls, but in terms of actually working inside of those entities, you don't feel a difference in how they act, in their motivation for profit, in how they desire to grow. So mostly you have actors that look about the same. The biggest difference is their tax status. Right. So all of that pressure that we were just speaking about comes from those health systems in approximately the same way. And then it's very interesting to see where the funds flows are looking to create an arbitrage opportunity, right? We've seen it in probably easier places where you took anesthesiologists or intensive care doctors and some bright person realized that there's a very small supply of them, but they weren't bargaining very well. And so they aggregated and then they bargained. and the price of healthcare went up for everybody, and those people who were bargained for did better, and the people who bought them did better. And that's just what happened, right? And you can see that happening over and over repeatedly. The most interesting space, I think, now is primary care, because the biggest value in primary care is not in primary care. It's not a huge arbitrage opportunity inside of primary care. It's the downstream effects, which is what the hospitals have known for years, which is why they have reluctantly bought primary care to protect their referral streams. But now that private money is entering the situation, it's a bit more of a race. Can you protect your referral streams, or are you going to get bargained against? So I'm going to be fascinated to see how this all turns out. It sounds like it might be useful if a company showed up that could help these physicians stay independent, aggregate them, help them bargain, and then do their back end for them. I don't know where you're going to find one of those, but I keep an eye on it.
Thanks. Good. Look, I think it's an interesting perspective that you bring there, Paul, on sort of the financial motivations. I think perhaps shifting a bit from the financial and more towards some of the people and patient and access components of all of this consolidation. I'm curious what you all are seeing in terms of, impact for better or for worse in patient care, right? Let's start there, given the consolidation and where you see that heading. Bijan, maybe we'll start with you.
I also want to defer to Dr. Singh, because I'm going to say things that I may be out over my skis on. I'll talk about it a little bit from the perspective of, I'm the private equity guy on the panel, and I'm usually...
Hold your applause.
I'm usually the one who criticizes my industry the most. I criticize the industry for lots of reasons, but one thing I will say, I'm not aware of consistent literature that shows private equity ownership of a physician practice or a healthcare entity leads to bad outcomes, with the exception of some important work on skilled nursing that I think came out several years back. I think the data is mixed, is what I'm saying. And I can speak to some of the good things that I think private equity can do theoretically, and private capital, which is to invest in growth, add de novo sites. Those are things that open access. I know that's what a lot of our companies do, a lot of my peers who are in this business. Net job growth, hiring new people because you want to plant a flag and open a new clinic or a new site to do something. That's positive for access. Now, there are negatives for access, because when you consolidate, you have bargaining power. The people who often get hurt the most are the patients. And by that, I mean financially. So there's lots of research that's come from lots of places, including Lee Moore Daphne at Harvard and others, that consolidation obviously leads to higher prices. Not just hospital consolidation, but also insurer consolidation. And there's robust literature on that. I can always speak to it personally. So my kids were in a pediatrics practice up in DC. This is 8-10 years ago. Privia sort of bought, the way they buy things, they bought that practice. And then I started watching the EOBs, and the sort of list price tripled. And that's just the Privia people are great people. I like them. I know them personally, the founders, but we didn't invest in it. But that's just what they do. So questioning what the economic incentives of various actors are, it's just sort of the root cause of how they were grown up. So I think there's puts and takes on patient access, availability of care, but I don't think the private equity story is all bad when it comes to those. But I'd like to hear what others think.
Yashaswini, maybe a good time to get the literature view.
So I don't disagree with anything that was shared. I think I can offer maybe a sort of a zoomed out perspective on these questions. So across industries, within healthcare and outside of healthcare, consistently the literature shows that when you have entities merging, where you have an increase in market share, market power, that results in a higher cost for whatever it is you're buying. It could be healthcare services, it could be an airplane ticket, it could be a Subway sandwich. And so consolidation increases prices. You probably won't find a lot of people disagreeing with that. High prices in itself is not a problem if you're getting better care for it. So if you get higher value out of higher prices, maybe you have shorter wait times, or you see an improved quality of your primary care visit. That's not a bad thing. We're fine paying more if we're getting better health or better healthcare out of it. As was shared earlier, in healthcare, we kind of don't see those so-called benefits bear out. And so when we look at, often proponents of these trends towards consolidation will cite efficiency gains as a justification for consolidating. Those so-called efficiency gains don't really bear out empirically. And then there are some real concerns that are understudied from an academic lens, at least, related to patient access and implications with the healthcare workforce. So the specific concern related to access is when you're in a system with high charge financial incentives, patients that present themselves as lower financial opportunities will be less likely to access care. Think uninsured patients, patients on Medicaid, and so on. That hasn't been quantified empirically in a systematic manner, but the theoretical concern is still there. And then increasingly, the last thing I'll say is, at least with the Biden administration, there was a focus for the antitrust authorities to looking towards labor market harms as a potential harm of consolidation in healthcare markets and more broadly. And there the concern is when you have employers who might be the dominant employer in a setting, kind of controlling how wages are set and whether employees are free to leave undesirable employment situations and so on via contractual agreements like non-compete and non-disclosure terms. There's a specific concern that consolidation can then, through those mechanisms, hurt the mobility of the workforce and the compensation of the workforce and so on. So those are, again, theoretical concerns that haven't been systematically examined, but an example of things that antitrust agencies would look towards.
Quality is really hard to measure, and I know quality was in that question somewhere. It's really hard to measure, no matter what anybody tells you. It's actually really hard to measure. What we do know is that when private financing takes over physician practices, more physician extenders get used. By the way, if you had your Google Scholar Alert set, you would know who wrote that. When that happens, that can be good or bad. So I'm not tarring anybody, right? If you have a bunch of physicians in a group and they're not using any physician extenders, so they're doing lots of tasks below their license, they should just be seeing more patients, right? The reason you can't get into your cardiologist is they're all busy typing. Now, if you put physician extenders in there and they are doing tasks to their appropriate license, that's a better thing. On the other hand, if you put a bunch of physician extenders in with not enough physicians and you tell the physician extenders to start diagnosing and treating things they maybe weren't completely trained in, that's a bad thing. So to Bijan's point, there's no good or bad actor here. There's no black or white hat in the rodeo here. There's just how you do the deal and what your appetite for doing the deal and your profit margin is. If you squeeze a little, you probably do a really good thing. If you squeeze a lot, you probably do a really bad thing. And so it's really hard to know where the good and where the bad is. And I bet somebody's going to study that at some point.
Anyone who's ever heard me talk about these topics will know what I'm about to say next, which is if you've seen one private equity deal, you've seen only one private equity deal. And so it's really, of course, I'm an academic, and so I can tell you in sort of broad strokes what the literature says, but the literature is estimating averages. And so you have an understanding of how the average PE firm behaves, or the average hospital consolidation plays out, what the average price effects are, but underlying every average is a distribution. And so it's important to keep that in mind as we get into maybe finer details of specific situations.
Let me just jump in on that. I think that's a really good point. One of the things, maybe for those who don't know, when a private equity firm buys a physician practice, the average, the typical, is because most physician practices don't have EBITDA, profit. Because physicians, when they run a practice, just distribute the cash at the end of the year. So there's no underlying profit other than what the physician's comp is going to be. And that's typically at the end of the year, they just distribute that excess profit amongst the partners of the practice. So the way the private equity firm creates the EBITDA on which they're going to apply a multiple, which comes up with the price, the EBITDA, the profit, times the multiple is the price they're willing to pay for that practice, is the physicians agree to cut their annual compensation by some amount to whatever a market number is. And whatever that market number is, or below market often, that gap created, the physicians agree to get paid less. That's the profit on which the private equity firm values that physician's practice. Okay? And then here comes the part that I don't like, which is why I don't do these deals. There's a thing called income rebuild. And income rebuild means, dear doctor, we took your salary down from $500,000 to $250,000. The way you're going to rebuild your income over the 5 years that the private equity firm owns this practice is often related to something called insourcing of ancillaries. And this is a healthcare crowd, so most of you will know what that means, but often the PE firm will not just buy the practice, the dermatology practice, they'll buy the dermatopathology lab. and then they'll encourage the physicians to insource all the biopsies to the lab that's also owned by the physician practice and also owned by that same private equity firm under the same umbrella, instead of sending it out to whatever the send-out lab used to be before the private equity. That's how you rebuild your income, because you benefit in some of the profit that lab generates. That's income rebuild. And in my mind, and again, the literature I think is unsettled here, but in my mind, you would think that leads to incentives to do more things, because everybody wants to rebuild their income. They're not bad people, they just want to rebuild their income. So say they took some of it out up front in capital, their current pay went down, and physicians have a remarkable way of forgetting that cash they took out up front and only thinking about, hey, how come I made less this year? Well, it's because you took $5 million out last year. And then you get to rebuild your income to the end. So when we talk about sort of what underlies really underneath the surface of that, that's the dynamic of, again, it's not good or bad, it just is, and that's how those deals are mostly structured.
Fascinating perspective. I think there's the patient element of this. There's also the physician element of this, and you were, Bijan, hitting on a portion of it, which is the compensation. But I'm also interested in, Paul, particularly in your work, right? As you're sort of helping physicians who desire that to stay independent, right? What are you seeing in terms of what is their mindset as they're navigating this, right? What are they looking for, and what are the folks who are looking for maintaining independence? Like what's their mindset going into it? The second, which I'll open up to the broader group, is what's the impact on the talent pipelines broadly of going through training and eventually knowing you're entering a market that has these consolidation dynamics and may have fewer opportunities for independent practice?
Well, that's a lot. Okay, so this is mostly an opinion piece now. I don't have much data on this. I just have all the docs I see and that I talk to. You really have to throw them into different typologies, right? There are docs that really don't want to work for anybody, badly. And that's great. They still want a good income. They still want to be treated fairly, and they still need to use electronic medical records. They still need to participate in value-based care, and they're feeling the squeeze. And that's where companies come in and help them do that, right? They can affiliate, they can get an MSO, they can reluctantly be purchased, and then they're very unhappy. So we see that whole group of folks. We also see plenty of people who, especially the younger docs, are coming out of residency, who don't want to limit their options by creating an asset that anchors them to a certain geography. And those are the folks who are really helping from the physician side to encourage this consolidation, because they want the ability, as though you were working in any other industry, to just move from job to job, or maybe you have a spouse that needs to take a job somewhere else and that's going to happen. The coupling up of physicians has skyrocketed with the increase in females in the medical profession, right? It's now actually majority female in medical school. And let me tell you, when you go through medical school and you're doing 80 to 100 hours a week, those are the people you see, and you're not seeing anybody else. So shockingly, there's a lot of two-doctor couples out there. They need flexibility to move around, right, to different jobs in different places in the country, and therefore owning a practice becomes a lot less attractive because you are cutting off your optionality for geographic reassignment early in your career, and they're willing to trade that independence to have that kind of freedom.
Bijan, any reactions?
Yeah, I mean, I also think about the pipeline of, and I don't have good stats on this, you guys might, of who's choosing to go to medical school today. I think that I don't know if that pipeline is less than it was. Obviously, the Guild controls how many medical schools there are, so we're not adding a lot of medical schools. I think one in the last 30 years that I'm aware of, maybe two. So one thing I wonder, I have kids who are in high school and in college now. My observation is that less people are interested in a career in medicine today than they were 35 years ago when I was finishing high school. And more people are interested in going to other careers. And I don't know if that's because it's not considered the prestige profession it was in the 80s and 90s, or because independence, there are different elements to independence, or because, boy, it's really hard work to be a resident and a fellow and building a practice over time. But I think about the consequences of this conversation on the upstream pipeline of who wants to go to medical school.
It's interesting. I've spent a fair bit of time with the large not-for-profit health systems on, their talent, right? And how do you sort of think about over time retaining talent in a world where most of these large health systems are now born of acquisition, right? Whether it's acquisition within the state, potentially acquisition outside. One observation is that what is I find often forgotten is this idea of also career pathing and mobility within the large health system that is operating as 6, 7 different entities, right? And so, and this is for the physicians, but it's also for the nursing workforce, for example, right? One of the clients I went into most recently, we went and just sat and spoke to their nursing panel, their nurse leader panel, right? And they were very clear. Look, I'm operating in this world where I don't actually have real visibility to, how do I go from an RN1 to a 2 to a 3 to a 4? How do I contribute to this health system in a way that over time allows me to, if I want to, coach, more junior nurses in the role. And so it was interesting that this system in particular, in taking sort of a leading role, really said, okay, we're going to really invest in not only building career paths for physicians, for nurses, for other parts of our clinical workforce, but transparently communicating them to everyone across a very disparate organization, right? Helping managers really think through, how do you have a conversation with, your employees on what it means to, move up a career ladder in nursing, to move, horizontally to some of the more IT-focused roles where nurses are needed, right? So I think that's a piece that's often forgotten is, for the physicians who are in the workforce, right? How do we support them as well in their sort of career and pathways? I want to shift us a little bit to the regulatory environment on all of this, right? And I guess perhaps it's a slightly dangerous subject with the politics of Tuesday, but I will say it obviously will have an impact, right, in the next 4 years, sort of what positions various regulatory entities are taking on all of the consolidation. And Yashaswini, maybe I'll give it to you first, having studied this subject, but what role do you think really the regulatory bodies, right, the FTC, the state agencies are going to play in managing the impacts of this consolidation over time?
Sure. So on the federal landscape, the Department of Justice and Federal Trade Commission are typically the agencies that are tasked with ensuring markets are competitive, and that includes healthcare markets. So at least in the last 4 years, we saw an increased appetite to challenge non-traditional forms of consolidation in healthcare. This includes, putting out a request for information for vertical arrangements between hospitals and physicians. It included the first of its kind lawsuit against a PE firm and its a PE-backed platform in anesthesia just last year. And so there's signals, at least, that the FTC of the past was, or current, interested in taking on newer challenges or taking on newer forms of consolidation in healthcare markets. I don't have a crystal ball, so I don't know if this will remain to be the case, but I think more broadly, in part due to conversations like this and literature put out by us at Brown and other colleagues across the country, there's a realization that this is something that warrants closer attention, right? I always say you can't solve a problem you can't see. And a lot of the issues with consolidation in healthcare markets has to do with underreporting and a lack of transparency and lack of disclosures. And so that's where on a state level, there's more interest and momentum to improve ownership transparency, for example. Let's all have a better understanding of when we say 80% of physicians are at present employed by a hospital or a corporate entity, what does that mean? And when we say Optum owns 90,000 physicians, but on the data you can see 5,000 physicians, that's not a rounding error. And so what does it mean when we say, physicians are owned by entities? Is it an affiliation? Is it an employment agreement? We really can't begin to fix some of the harms of consolidation if we cannot agree on the magnitude of the problem. And so there's been state of efforts across a variety of states with varying degrees of success to improve oversight of healthcare markets, improve transparency of ownership disclosures. Some of this, I think, we'll have to see how it evolves in real time, but I'm hopeful that folks are at least paying attention. So I'll be paying attention as well.
Yeah, you can hold two ideas that are somewhat contradictory in your head. It's a pretty over-regulated area, right? Trying to do anything in medicine is really hard because of all the lawyers you have to employ immediately to let you go to the bathroom. At the same time, if you are not paying attention, bad actors will run wild, right? So we saw that with the No Surprises Act. I was in Texas when the freestanding ERs put themselves up and said, we're out of network with anybody, and the law says if you're having an emergency, the insurance company has to cover it at billed charges so that the patient is held harmless. Would you like to guess what it costs to get a strep throat culture in a freestanding ER in Texas in 2018? It was $7,000. $7,000 for something you get at urgent care for $80, right? But I was at Blue Cross time. We had to pay it. Law said so. How you like those premiums, right? But the freestanding ER folks were making out like bandits. What eventually happened? You got federal bipartisan action and the No Surprises Act saying, that is a bad actor and we will no longer tolerate this. But it took years and literally close to $1 billion of overcharging. So it's too regulated and it's not regulated enough. There you go.
It's a difficult conundrum, the regulatory environment. I am interested also, I mean, we've talked a lot about the sort of the provider lens of this, but Bijan, you were also mentioning, right, that there's obviously a set of investments, right, that firms like NaviMed and private equity broadly is making across the spectrum here, right, that aren't as provider focused. Where do you see the puck skating, right, in terms of consolidation that maybe even goes beyond, pure provider world in the healthcare space?
I think every single segment of healthcare will continue to consolidate. We invest in pharmaceutical services, which is a big thing down in this part of the country, and lots of that segment has already consolidated, like CROs and manufacturing, but some of it had not. Clinical trial sites, as an example. We happened to make an investment in a company here in Durham 6 years ago, when that was a pretty unconsolidated space. Tens of thousands of clinical trial sites where phase 3 studies for pharma are conducted. Most of them are not the academic medical center, although they are a site on that phase 3 study. Most of them basically look like a doctor's office because the doctor realized that running trials was either more enjoyable, more lucrative, whatever, and so eventually over time gave up their medical practice to just be a trialist and run trials in a standalone clinical trial facility. It looks like a doctor's office, just does trials. Well, that space went from being entirely unconsolidated to there being 30 private equity platforms in that space in the span of 4 years. And that's but one example of, I think, taking things that are what I call on the edge of the network of healthcare and consolidating them. So ASCs, ambulatory surgical centers, have been largely consolidated by both payers and private equity. I think there are other things in sort of office-based procedures that are being consolidated by private equity right now. I mentioned pharmaceutical services. In fact, it's a little bit of a struggle for us as a firm because we like to enter places that have not yet been consolidated because we like to be the first ones and then sell it to somebody bigger. And a lot of spaces have been consolidated. So we're kind of scratching our heads saying, okay, what's the next place we need to be thinking about as the place that's not consolidated? And shockingly, lots of places are consolidated right now. So it's tougher and tougher.
So it's really interesting insight on the market, right, and how much consolidation there really is. I think, Paul, maybe to you as well, give us a little bit of insight into the business model at Allo, right? How are you helping physicians like navigate and really think through what it means to be independent and then enabling it you mentioned the back end, right? How do you enable it on the back end?
So we start out with the well-founded supposition, again, Dr. Singh, correct me, but I think I'm right, that independent practice is lower cost for everybody involved, and it is at a minimum the same quality as the consolidated entities, but there's a lot of suggestion the quality is actually higher if you're not consolidated. So we start out with that idea. We'd like to save money for society, and we would like to have at least the same quality, if not better. When you start with that perspective, then you go to the docs who are independent, especially the ones who are struggling with my EMR is out of date, or God forbid, this is actually still out there, I'm still on paper charts, and I don't get any of these quality bonuses, my income is going down, how do I make this work? And then we show up and say, hey, we actually know how to do all this. So if you would like to join us, not be owned by us, but join us, we'll get a contract with you to do all these services for you. We'll give you an EMR. We'll take care of your revenue cycle. We will do all of the negotiating with the insurance companies for you. You can just run your staff, practice medicine, and still be an owner. So the culture in the practice is your culture. The people you want seeing the patients are your people. But we'll do all that other stuff that maybe you don't want to do and you're 100% not good at. And your income will go up and you will still be independent. You'll be more efficient. You can participate in value-based care. So that's the thesis of our company, that we're going to do those things in North Carolina to those independent primary care physicians who want our help.
It sounds like an amazing, like, why would anyone say no? And I don't say that jokingly, like, it sounds like but it sounds like an amazing proposition. I mean,
yes.
Who are the physicians that it doesn't fit for, or why do you hear no?
If you're already in a large group of physicians, you probably already have a state-of-the-art medical record. Your contracts are probably pretty decent. You probably have your own revenue cycle team, right? So you might want to talk to us, and we go through the whole thing, and they go, well, there wasn't that much to gain. Like, it looks nice, but it's not that much to gain. So we're actually a lot more successful in the 2, 3, 4-person practices than we are in the 20, 30-person practices. Because generally, if you're a 20 or 30-person practice, these things have already happened to you. You've either been consolidated, right? So you're already owned by a hospital. Every person you've ever met has offered to buy your practice. Every hospital you've met, every PE person you ever walked through a hotel with, and you've never wanted any part of that, which means you've already figured out back-end stuff and how to do it decently, because otherwise you would have already sold your practice. So essentially, we're there a little late, but hopefully that means that they'll stay independent, because at the end of the day, we actually don't care if we're the one winning the practices to our business, as long as they're not getting consolidated.
Yeah. Well, this has been a wide-ranging conversation already, but I do want to open it up to the audience, and we don't need mics, we don't have mics, just speak up loudly. But what questions do folks have for the experts on the panel here? We'll go here first, and then coming up there next.
So thanks for being here. So today we see about 3/4 of physicians are now work for hospital systems, as opposed to 40 years ago where the reverse, they were independent. And so our last panel with AI, do you see AI as a lifeline for the independent practices, or kind of the speedway to their demise?
I think that's directed at me because you were looking at me. I definitely do not see it as a speedway to their demise. Full disclosure, I did not see the last panel, so I may say things you're like, that's not what that guy said. I think it has a potential to be unbelievably helpful, especially with the admin burden. It is 100% not there yet, no matter what anyone is telling you. But when you look at what it can do, I would love to be practicing in a room where AI is just listening, and when I walk out of the room, my note is written and my bill is dropped. That would be phenomenal, right? Because I'll only speak for primary care because that's what I'm closest to right now. Generally, for every 6 hours you're in clinic, you are charting an extra hour afterwards. So if you do a 12-hour day, you then go home, see your family, put your kids to bed, it's 9:30, you open your laptop and you chart till 11:30, then you close your laptop, you go to bed, you get up at 7 and you do it again. That stinks, right? So if we can get AI to where you go home and you just close your laptop and you're done, that's a huge win. Feel free to disagree.
I agree. I think one of the questions on AI is the behind the scenes sort of back office is obviously the first use case. One of the things I think about 10 years forward is the front facing use case, the patient facing use case. Is it always going to remain a tool? So will RVUs, how physicians are paid, go down because you have to spend less time on a work RVU performing a service because perhaps the AI is doing something? Or will we have CMS issued reimbursement codes for an AI doing something to compensate the practice for the provider for having spent the money to buy that AI? There's a bunch of questions that are very theoretical right now, but I think about sort of not today questions, but I think will emerge, going forward. The dataist as the physician, you're just the front person, but there's an AI that you have to probably pay something for, and how are you going to get reimbursed for that? Because you have to spend money on it. So I think it opens up some avenues, also potentially avenues for abuse. In terms of fraud, waste, and abuse.
The other thing I'll add is I think what will get in the way that is underestimated today, in part because the tools don't create the perfect 12-hour day, right, and nothing else, is the change management aspects of all of this. And I think we're seeing it in the first iteration of now the Gen AI tooling, right, which is to say that when I work with providers that are now implementing AI in parts of their practice, it takes workflow like real workflow change, right? For a nurse on the floor, for a physician, for everyone involved, right? Workflow change is just one element of that, right? But it also takes the ability to understand and use the tooling insofar as that is required, right? And all of that is a really, really big lift in an already incredibly complex environment where practice is already complex and hard, right? And so I do think that's the thing. I don't see it as an insurmountable barrier. I just see it as something where the focus right now is more on the technology, the data to enable it, and I see less of the focus on the change management to pull through the magic of what this can do for clinical practice. The change management is going to be incredibly important. I think there was a question back there, and then we'll hop around. Go ahead.
Again, thank you for your time. As we're kind of seeing like the private and public sectors kind of become more and more intertwined, do you believe that companies that are executing these acquisitions in a private sector have some sort of public obligation, especially when it is concerning patient care?
Yes. I mean, it's right. If you're taking care of humans, you owe them to take care of them. That's hopefully what most people who go to med school wish to do. There are a lot of things that get in the way. You're tired, right? You're overworked with admin stuff. So I don't think physicians always have their best foot forward. But certainly in the trenches, I'm still seeing everyone try desperately to do their best. And we have a lot of things getting in the way. So when I just say yes, I was being a little sarcastic, but yeah, if you're going to buy these practices and you're going to squeeze money out of it, you do have an obligation to society in general to make sure you do it in an ethical way.
Private equity hasn't really done much justice to like skilled nursing facilities. That's been a shame, and I don't think that was.
Yeah, well, as Bijan was saying, like that's the primary proven. Well, that wasn't good.
Wasn't a good experiment.
Yeah.
My take on that is, this might just be my take here, but I believe that private equity or any for-profit investor, retail company, all of these entities operate as they should operate, right? They have a mandate to their investors and their shareholders, and they are delivering on that promise. I don't see anything wrong with that. So then the question is, how can we make sure markets are supported given what we understand about the incentives of actors in those markets? And so I see it as less of an obligation of PE firms or hospitals as needing to meet that obligation towards patients, but more of us as a society and maybe policymakers. Like, what is their role and their obligation to make sure that we have enough guardrails around particularly the bad behaviors? Because there's nothing wrong with behaving as a for-profit private entity would. And as economists, we should be rewarding that. We should be rewarding efficiency. I don't see anything wrong with it, but at the same time, there's enough emerging evidence that some of the effects in hospitals and nursing homes, it's not really what we want from these types of arrangements. And so, to me, that's a call for greater sort of policy support to make sure that the failures are at least in check.
The tough part becomes in healthcare and in maybe any industry. That's exactly right what Dr. Singh said. And yet, so we had COVID, some abuses in nursing homes that we all know about. We had the prior stuff that went on in the kind of late 90s nursing home kind of stuff with Manor Care and others. And some of you might know about that, private equity ownership. And finally, a year ago, there was issued some proposed rules around minimum nurse staffing in nursing homes. And the industry lobby is just up in arms. It's probably going to get overturned in the next administration on Loper Bright or other concerns around the regulatory state Chevron deference. So it may not actually end up happening. And so we just happen to live, in a place and at a time where all of that is exactly true, and yet actually getting regulation completed and implemented is actually getting harder, not easier.
We have another question in the front of the room here, yeah.
Yeah, it's changing a little bit. Full disclosure, I've been in private practice management for 24 years. I've been through the whole cycle. I have run a very large independent group that was acquired, recently left that and actually started my own new group with no intention of ever doing that again. In my particular specialty, and this may be disagreeing a little bit with what's said earlier, we're actually seeing the big private equity groups fail. They are very much failing, starting to fail. Is that, I guess the question is for the groups, do you see that? I'm in radiology. Is that happening in other places? Like in radiology, if you look back 30 years, we've done this before. We did this in the late 90s. It all grew up, they all failed. Now we're doing it again, or have been for the last 5 or 10 years. Is that something you're seeing across other specialties,
Yeah, I think there have been some signs of some underperformance or early fissures.
I can tell you the two biggest in radiology are
radiology for
teetering
sure.
on failure.
And there's a large derm one that was taken over by the lenders. So the physician's equity in the top entity, where they get rollover equity, was wiped out. Stepping up a level, I would say, why does a consolidation of physicians fail? One of the sort of things you're betting on when you buy a physician's practice, other than the income rebuild thing I mentioned, is that how does a physician practice actually grow? Population, you see more patients or charge higher rates. And there's kind of a lever of control you don't have after a certain point on those two things. You can, open new clinics, but the markets are saturated in some areas. So it's actually kind of hard to grow the revenue of a physician practice the way private equity firms underwrite revenue. We don't do physician practice, but we're typically looking for 20 or 30% revenue growth in the companies that we invest in healthcare. That's hard to do in a physician practice. But you borrow a bunch of money predicated on that model, and then when it doesn't happen, bad things come. And then I said, there are not a lot of buyers of these consolidations of physician practices. The large staffing things that existed for years in anesthesia and stuff, for the most part, have said, I don't want to own dermatology. I don't want to own, ophthalmology roll-ups. That's not what I do. I do sort of hospital-based medicine, emergency medicine, or anesthesia. So there really aren't a lot of buyers. There's this new emerging category of drug distributors who are buying the ones that do heavy infusions. They're buying some oncology practices and some other ones recently. But for the most part, there's sort of the buyer of choice is the next private equity firm, and at some point you run out of buyers to buy you.
Completely agree. One thing that was said earlier, I think that's also contributing in radiology at least, is the shortage of physicians has given the choice. People coming out of school, they don't want to work for a large private equity. So they don't have to. So that these big private equity sponsor groups can't hire.
On the other hand, I wonder if they also want to work for large health systems. Like there's
Good point.
Great discussion. Can any of you comment from an international perspective? So this is the U.S. healthcare system, the biggest in the world, maybe very specific. What's going on in Europe, Asia, other parts of the world? How does that compare? What can regions learn? Is there?
How much time you got? So I've been a physician in the Costa Rican healthcare system. My daughter just spent 4 years in the UK under their healthcare system. So I have a reasonable experience to compare. Nobody's healthcare system is very good. So you can also hold two competing thoughts in your head. One, our healthcare system isn't very good, and lots of other countries get better outcomes for less money. Also, their systems aren't very good either. Right? While I was in London last time, there was an ambulance strike. You know what they did? They came out on the news the night before. They literally said this: "Don't get hurt tomorrow." Don't get hurt tomorrow? Don't get hurt tomorrow. And if you do, have a friend put you in a car and take you to the hospital, because no one is coming. Okay, so the UK system is broken too, right? But way cheaper than ours, right? The Costa Rican system I actually was extremely fond of. Primary care is a right for everyone inside their border, not just citizens. So if you are in the border, you can see a primary care doctor. They actually do a really good job. They do this because they don't have an army, so they can spend a lot of money on healthcare. But comparatively, on a per capita basis, they spend way less money than we do and get better outcomes, right? So They have a very nice system down there, but it's not perfect. Your first stop is not a doctor, right? They've perfected the physician extender model. If you go into primary care, you're going to see someone who's well-trained to recognize things that aren't normal. And if it's not normal, then you go see a doctor. And if you come in for your physical and everybody's normal, you are not seeing a doctor. It can work.
I can comment on the PE side of things because that's my area of research. I actually had a paper accepted. Shameless plug for my Google Scholar alert.
Why not?
But it'll be out in the New England Journal of Medicine in a couple of months. And the title is, the rise of PE, not a uniquely American phenomenon. And the thesis of that paper is, we tend to think we have a market-based healthcare system with private firms, private actors, private payments. And so if we see the rise of private capital and private equity, of course it would happen in the US and not in countries with an NHS or other type of healthcare system. But in fact, you see the same firms deploying the same strategies in countries around the world. The only difference is maybe the tolerance for this activity differs depending on kind of political landscape. And so some countries in Europe have been swifter to act to put those checks and balances while they understand how these trends will affect care delivery and patient outcomes. Whereas in the US, we have evidence that this trend is here, it's here to stay, it's changing care delivery, but yet, political will and momentum is still lagging behind.
Real quick, so it seems like with consolidation, the barriers to entry are higher. And with that, I would imagine it's a lot harder to have clinical innovation. So can you speak to what it looks like in the age of consolidation?
I don't invent anything.
Let's see more about clinical innovation. What do you mean by that?
Just how we move healthcare solutions forward, like new drugs, new technology, new ways of treating patients.
I can see both sides of that. So larger entities might be slower to adopt things. I don't will on anybody to have to sell to a hospital system a piece of healthcare IT technology. It's the worst process you could possibly live through as a salesperson. 18 to 24 months, and the committee has a committee, which then has its own committee. So not all large entities are good buyers. That having been said, pick your poison. Would you rather sell to 10,000 physician practices one by one, your clinical innovation, your new device, your new drug, your new AI thing, or would you rather sell to fewer numbers of buyers with deeper pockets? I don't know what the right answer is. I'm not sure there is a right answer, but I think neither is maybe great, but they do require different things of vendors and innovators to do. I will also say one thing, having invested in startups in capital days, it's really hard being a little point solution startup selling to a hospital system, any clinical innovation at all, because especially today versus even 10 years ago, because you get subsumed in the, I want to consolidate my vendors down to one, and by the way, Epic told me they can do that same thing, which they tell everybody about everything. So I think it's even harder today, being the little guy trying to sell a clinical innovation. So basically I'm saying it's all hard.
We'll take one more question. Yep, go ahead.
Hi there. So I've had the experience of actually working on the pharma side of the healthcare industry, as well as now working on the payer side for Blue Cross and C. And one sort of bad actor that everyone seems to agree is the worst is PBMs. And so I was wondering if y'all could share just any takes on PBM consolidation and whether or not you think going forward there will be any moves to break up any of the large PBMs.
I'll end that with you. Are
So,
they going to break them up?
well, again, I don't have my crystal ball with me today. Later. No, so I know that a pattern for the antitrust agencies is when they're concerned about an area of consolidation, they first start with requesting information, right? We saw that with an RFI put out for vertical consolidation of physician practices, and I believe earlier this year they put out a request for understanding how large insurers are vertically integrated with PBMs, are vertically integrated with physician groups. And so just based on that, I see that as a sign that at least folks are paying attention. Whether that results in the formal filing of a complaint, again, don't have my crystal ball with me today, but it's a sign that the right people are paying attention.
I agree with that. It's one of the few bipartisan areas in the town I live in DC is that PBMs are awful. And the way I know that the PBM industry is realizing that they're perceived as the enemy is that there's lots of billboards up at DCA Airport if you go through there. And a lot of them are the PCMA, the PBMs Association. That's where you put up your billboards if you want the member of Congress to see, we're the good guys. But my other flip answer to that question is, if you listen to United Healthcare's earnings calls, there's this very funny thing that's happened in the last few earnings calls where they say, oh yeah, like we're getting killed on specialty drug costs. And then on the flip side, they say our PBM has had record cash flows and earnings these last few quarters. And so there's this analyst from JP Morgan, who's great, Lisa Gill, and she always asks the same first question. They go to her and she said, this was just a few, I said, can you help me reconcile why you're getting killed on specialty, but you have record, PBM earnings? And they hum and answer the executive. But look, that's the point. And the question is, are the benefits that PBMs are receiving being passed up to the employers for whom they work? And that's always been the line they've said, and what I don't know, and maybe somebody else on this panel does, whether that's actually the truth or not. Because what it's supposed to have done is reduce premiums. I think we can all say it probably has not done that, and it's just created a market distortion.
Because no one's doing it, I'm going to defend the PBMs. But just barely. In the beginning, a lot of that made a lot of sense because somebody had to watch the really expensive drugs. Much as insurance companies had prior auths and medical necessity for PET scans, right? Which probably annoyed you, but it was necessary. I was in the business, not with a PBM, but in the medical side with Blue Cross when the hepatitis C cure came out. Are you all old enough to remember that? Okay. It was a while ago. I feel great. So this pill came out. Hepatitis C was an incurable chronic disease that eventually caused liver failure or liver cancer, and you would die of it. And lots of people had it. And then they invented a pill, for gosh sakes, a pill. And you took the pill for 6 weeks, and then you didn't have it anymore. Ridiculous. Also, this 6 week cost $45,000. Ow. We got requests from well-meaning doctors to treat their patients with hepatitis A and B with a $45,000 course of medicine that only treats hepatitis C. So if you don't have somebody watching your $45,000 pill, people will waste your $45,000 pill. That was the whole idea behind PBMs, along with trying to work out better deals. But trying to do all that stuff is not a crazy idea. I do think where we are now is pretty crazy. But then, and I'm going to ask the economist next to me, and everyone should have one. If somebody like Mark Cuban can walk in, throw down and say, enough of this, I have cost plus